Nursing Dudes here, helping you survive nursing. Today we'll be talking about lymphoma. So first we're going to start off by defining lymphoma. Now a certain professor of mine told me that you always need to break down the words in order to understand its actual meaning. So let's take a look at lymphoma. Lymphoma. Okay, so we're going to break it down. We have lymphoma. So when you're thinking lymph, you're thinking lymphatic system. And when you're thinking oma, you're thinking carcinoma. Which comes down to cancer of the lymphatic system.
So we're going to start with the hierarchy of the cells. We all know that everything comes from stem cells. Then we have the lymphoblasts, and we have lymphocytes, which are broken down into three cells. B cells, T cells, natural killer cells. But for this purpose, we're going to stick with the B cells. B cells start in the bone marrow, and then once they become teenagers, they're kicked out of the house and into the lymphatic system, where they begin to mess things up, and that's where we get lymphomas.
So you're probably wondering, how can you differentiate Hodgkin's lymphoma versus non-Hodgkin's lymphoma?
Please tell me, Dino.
Hodgkin's lymphoma is characterized by the Reed-Sternberg cell, and it's far more curable, 75% actually, than non-Hodgkin's lymphoma. So this brings me to Reed-Sternberg cells, which are in Hodgkin's lymphoma. So you're probably wondering what they are. Basically, simple way of thinking of them is that they are B cells that are just crippled. It looks like somebody chewed on them or something.
What does that have to do with anything?
Glad you asked, son. So basically what happens, inside of the Reed-Sternberg cell, the inner Biber gets a little bit out of hand, and NFKB, which stands for nuclear factor kappa B, loses control, and it's unable to just cause inflammation sometimes, and it just causes inflammation all the time. And put your feet down. Take your glasses off. Now. Okay. Alright, okay, great. This brings me back to promotion. There are many things that can promote inflammation, such as pesticide exposure, smoking, obesity, eating crappy foods.
That's a good question, animation. Yes, it can. It can spread to the lymph nodes, and then Hootie over here in the later stages can even progress into the blood. So because we're dealing with the lymphatic system, most of the symptoms are swollen lymph nodes. The most common ones are the cervical and the supraclavicular ones, and then you can have the auxiliary ones.
Supraclavicular!
And then the auxiliary ones, and then you can also have mediastinal masses, so you're going to have like these lumps in your chest. Then you can have B symptoms, which are the more aggressive symptoms. I like to think of it as, like as if you ran a marathon in the middle of the night. You're going to have these unexplained weight loss, you're going to have lots of night sweats, you're going to have a persistent cough like you're hacking up a lung, and then you're also going to have an enlarged spleen or liver. And we know that the spleen and the liver are both used for
filtering!
Very good. So because they're filtering, they're going to try and filter out all the bad cells, and then eventually they're going to become enlarged because they're overworking and your body's...
because of all the backup!
All the backup.
You doing it? Okay, cool. So this brings me to treatment. Basically there's chemo, and then there's radiation. Chemo is more of a broad way of treating cancer because it can have an impact on the entire system, whereas radiation sometimes can be more specific, just onto one simple point. Now, I'm not going to talk about all these meds in detail, but what you do need to know is the side effects. Adriamycin, cardiotoxic, so you need to have an echo or an EKG to keep track of the side effects. Bleomycin, pulmonary toxicity, so you might have problems with the lungs, which can impact breathing, and O2 sat. And then vincristine is neurotoxic. Lastly, there's dexamethasone, which is lymphotoxic, which can decrease a person's white blood count and eventually lower their immune system.
So now we're going to talk about staging. And for lymphoma, you use the Ann Arbor staging method. So basically, stage 1, 1 nodule affected above the diaphragm. Stage 2, 2 nodules affected above the diaphragm. For stage 3, there's 3 nodules affected. 1 above the diaphragm, 2 below the diaphragm, etc. For the 4th stage, organ systems are affected. And these organs could be the lungs, the liver, and even the bone marrow. Now, how do we use diagnostics to figure this out? Now, the trick is, if you don't have a biopsy, then you don't have the cancer. There's no proof behind that. So, for the trick with the biopsy, you want to use a large bore needle, so you can collect as much of the fluid and tissue for sampling as possible. Now, we can also use a PET scan. We all know about PET scans. Now, there's a lot of hematological things that we can do. There's immunophenotyping, which is basically just checking out all your genes and making sure, is it the B cells that are affected, the T cells, etc. There's cytogenetic analysis, so you're looking at your chromosomes, and then there's gene expression. So you want to see, are genes turned on or genes turned off, what's causing this cancer. And the last one is the polymerase chain reaction, and that's just basically going to see if we give you a certain type of treatment, are you going to react to the treatment the way we want you to, or do we know that you're already not going to react to that treatment? So this leads us to non-Hodgkin's. So the initiation process is a little different than the Hodgkin's lymphoma. First, you get a little gene activated. Usually the oncogene gets activated and then causing the cancer. Next is the tumor suppressor gene gets inactivated, so now your body is kind of defenseless against the tumor. And then you have an error in the gene arrangement. Somehow something was, like the histones turned something off, now something's not right with your genes. Next, you have a viral gene that gets integrated into your system, like the Epstein-Barr virus. The way I like to think of it, like a dinosaur attacking the town. Now the town's open for fair game, and it's just gonna get destroyed now.
So for non-Hodgkin's lymphoma, symptoms are very similar, but they might be a little exaggerated. For example, aggressive symptoms for non-Hodgkin's lymphoma. You still have organ growth, however, it's very rapid. You still have B symptoms, and you're starting to get increased LDH, which is a little different than for the Hodgkin's lymphoma. Then for indolent non-Hodgkin's lymphoma, the organs are still getting bigger, so you're getting splenomegaly, hepatomegaly, but it's at a not very aggressive. It's at not an aggressive rate, so it's just slowly increasing.
How we gonna treat it? Or see how. We got Rituxan. It's nephrotoxic, so you want to check out the kidneys. We got Cytoxan, which is pulmonary toxic, so it's going to affect the lungs a little bit. We got Adriamycin. That one's cardiotoxic, so we're going to have to do EKGs and echoes. We're going to have Oncovin, which is neurotoxic, and prednisone, which of course is immunosuppressant, so it's going to make you more susceptible to other things. CHO, those ones are the classic chemos. Now how else can we treat this? Can we use stem cells? Yeah, we can use stem cells, but the only thing stem cells are going to do is they're going to help you tolerate the treatment a little bit better because the chemo is hard on your body. So therefore the stem cells, the autologous stem cells, which are your own stem cells, those ones will help you just kind of tolerate the chemo a little bit better and hopefully make your cure a little bit smoother.